Well, if they will allow me to share the
Yes, sir.
screen.
You can.
Right.
You're on screen.
Yeah. So at the outset, let me say that I am as confused as you people are about what is this topic doing in an obesity symposium. Maybe like, yeah. So maybe like, vitamin D, we are trying to blame vitamin D for all diseases from common cold to cancer. Similarly, obesity, since we don't know any reason, we are trying to find different areas where obesity cause can be found. And this red colored slide is just a warning that oral cavity is as important, not just for kidneys, but for a lot of systemic disease. And honestly, ignoring oral health leaves a bad taste in the mouth. An apple a day keeps the doctor away, but poor oral health keeps everyone away. We are all familiar with it in occasional cases when we have people taking talks to close proximity. Whether it's the oral cavity, you look at the cause or an effect, both are important. Our mouth, as we know, is a window to the manifestations of systemic disease. And oral diseases, as pointed out by the chairperson, can lead to a variety of systemic illnesses. So like we are all trying to find some nexus or some axis, we have a mouth, body connection. And as pointed out by Dr. Jaikumar, the mouth-body connection is in a variety of ways, and I'll pick up one by one. The Surgeon General reports that at least 80% of American adults have gum disease, but the impact goes far beyond the mouth. As he said, it could lead to Alzheimer's, dementia, stroke, respiratory diseases. This is understandable, because it could, the oral hygiene could be probably one of the reasons. But then Jaikumar also pointed out, and very rightly so, that people with gum disease are twice as likely to die from heart attack. So this is the connection. As we were trying to find out why in obesity, it's a very simple connection, but being obese significantly increases the risk of periodontal disease. And it's always good to scare people about the effects of any disease, that it can lead to sexual and reproductive problems. Cancer, yes, as I said, men and women with a history of gum disease are 14% more likely to develop cancer than those with healthy gums. And of course, diabetes and bleeding gums increase your risk. Osteoporosis, again, studies have shown a significant connection between periodontal disease and osteoporosis, especially in women. Arthritis, again, was pointed out by Dr. Jaikumar. In fact, most of my initial remarks have been very rightly talked about by our chairperson. And so this slide actually points out that we have problems all around due to poor dental health. But did you know that adults with tooth loss may have a higher rate of even CKD? And if you look at this World Kidney Day poster, oral symptoms are observed in 90% of patients with kidney disease. And oral signs also of advanced renal disease, we have all seen. This talk is more towards, the internists, physicians, primary care physicians, dietitians, and some of the nephrologists might find it a little basic, but we see pallor in mucosa, we can see the breath, we can feel the breath that smells like ammonia, stomatitis, and xerostomia, again, is a very important area, and I will dwell on it a little bit. But there are radiographic abnormalities and possibly delayed healing. So if you take the OPG, you will see that there is demineralization of bone, tooth mobility, socket sclerosis, calcifications, and all of it has some bearing on CKD. As pointed out by Dr. Jaikumar, oral infection or periodontitis can lead to cardiovascular disease. Specifically, one has to be scared of endocarditis, and a lot of cardiologists would probably ask you for prophylaxis to be given in patients with valvular disease if they undergo a dental procedure. So oral health related quality of life in adult patients with end-stage kidney disease undergoing renal replacement therapy. This systemic review was in BMC nephrology, and the oral health related quality of life generally suffers in patients with ESRD who are on renal replacement therapy. The common orofacial problems associated with CKD are in all aspects of the mouth, periodontium, oral mucosal lesions, the bone, cortical bone, the tongue lesions, and the salivary gland. And xerostomia would be very important, and we'll come to it a little later. We've seen this, we've discussed this, that there is a bad odor, metallic taste, and all that will help in reducing the food intake. Uremic stomatitis, enlarged salivary glands, which we know part of it could be due to hypoalbuminemia or hypoproteinemia, and decreased salivary flow. And you will see later on why this xerostomia or decreased salivary flow becomes a very important area. So the outcomes of poor oral health, as pointed out by our chairperson, is it acts as a source of inflammation. It could contribute to infectious diseases. And we know a lot of infections which can start from the oral cavity, specifically the fungi. And in transplant patients, we are very, very careful of fungal infections in the mouth. It can contribute to atherosclerotic complications. And most importantly, as I mentioned, various changes in the mouth can lead to protein energy wasting. And we'll see one by one all of it. Gingivitis and periodontitis are seen more frequently in end-stage renal disease patients, and we've all seen it. Repeated anticoagulation on dialysis predisposes these patients to gingival bleeding, and again can facilitate bacterial colonization. And periodontal disease has been reported to progress in severity across all segments: pre-dialysis, peritoneal dialysis, and hemodialysis. So oral cavity care is very important. Oral hygiene is extremely important if we need to prevent that. Periodontitis may act as a potential cause of local and systemic inflammation in CKD. So that much was for inflammation. What about infections? Periodontitis represents a potential source of episodes of bacteremia, especially in transplant patients. And a study showed that 32% of end-stage renal disease patients and 11%, if you compare, 11% of healthy controls had fungal hyphae through microscopy and buccal smears. So the incidence of fungal infections much higher in end-stage renal disease. We discussed in passing about the contribution to atherosclerotic complications. So periodontitis exhibited dyslipidemia and dysglycemia in these patients. It may represent a risk factor for atherosclerosis and thromboembolic events. The treatment of these periodontitis infections can actually reduce the incidence of coronary heart disease and could be one of the preventive strategies. You must be wondering, how does oral cavity contribute to protein energy wasting? And we know that oral diseases contribute to it in a variety of ways. But most importantly, it's dryness, pain, bad taste, hardly any interest in eating, and this may lead to anorexia and nutrient deficiencies. But again, an important area which we miss sometimes is secondary hyperparathyroidism. And I think most practicing nephrologists have seen the bone cysts in the palate of patients who have been very badly managed hyperparathyroidism and with very, very high PTH. So parathyroidism can lead to loosening of teeth, bone changes, and so on. So a possible contribution of poor oral health in uremia will be mainly to reduce nutrient intake and protein energy wasting through different means, right from uremia, having psychological issues, poor oral hygiene, drugs, xerostomia, and so on. Now, this area is important, and we do not possibly pay adequate attention to the patients who cannot eat because of dryness. And we know for sure that uremic dryness is there everywhere. It's there on the skin, vagina, oral cavity. And much of it is caused by some of the drugs which we use, especially antiemetics, antihistaminics. Some of them are on antidepressants and some antihypertensive drugs, so especially the centrally acting ones. And these can reduce the salivary flow, creating conditions as xerostomia, which may ultimately affect both satiety and diminished nutrient intake in CKD patients, eventually leading to malnutrition. And this is the list of drugs, of which I think important for us is anticholinergics, antihypertensive, neurologically acting drugs, and antihistaminics. So this is known to all of you all, that when you have a renal disease or a dialysis patient or a transplant patient and he has to go to the dentist, fortunately, most dentists ask for a certificate from the nephrologist for various reasons. For dialysis patients, you need to schedule his dialysis, you need to decide about heparinization, and therefore his dental work or treatment is important. From transplant point of view, it is important that he should be not put on drugs which could interfere and so on. So another area of transplant which we must discuss as far as dental health is concerned is that all transplant patients, we all know, undergo dental health examination as part of kidney transplant evaluation process. Serious dental infections can delay the transplant, can even prevent it, and being, the approval for a kidney transplant is delayed, which of course, eventually you get it. But one needs to be careful about oral health from that point of view. We know that immunosuppressants, antihypertensive drugs, many of them cause gum hypertrophy. And of course, transplant patients are very, very prone to fungal and other oral infections. So that's the connection between transplant and the oral cavity. So this is my last slide. And to summarize, as pointed out in the beginning itself by Dr. Jayakumar, that the mouth is a powerful diagnostic tool in the clinical assessment of systemic health. It's a mirror for either systemic disease or a mirror to the side effects of drugs. And we know gum hypertrophy with calcium blockers and CNIs and so on. So many systemic diseases, and we know about HIV, we know about diabetes, etc., but it includes chronic kidney disease and transplant. They will have oral manifestations. In fact, oral symptoms are observed in almost 90% of patients with kidney disease. And the coordination between a dentist and a nephrologist is very important. And the point which I stressed, I will summarize again, that drugs could be an important cause of oral signs and symptoms, especially xerostomia, gum hypertrophy. And dialysis patients need to coordinate with the nephrologist before the dental visit to avoid bleeding complications, the use of drugs, and altering the dialysis schedule. So ladies and gentlemen, look at your patients and explain to the patient that for heaven's sake, look after your mouth. You owe it to yourself, and more importantly, you owe it to people around you. Thank you.